one thing that I promised our audience we were going to talk about at the beginning is the use of some assay, flow cytometry, next generation sequencing, to look at minimal residual disease. So let me give you an example of something at this Congress that was presented by Dr. Lambert. A really nice oral presentation looking at WT1 overexpression, which is informative in every leukemia patient. You don't have to worry about flow phenotypes, immunophenotypes. You don't have to worry about specific fusions or mutations to follow. You can look at WT1 overexpression using an RT-PCR-based assay. And so she presented a very nice study looking at the prognostic significance of that. And what she found was if at the end of induction, if the patient did not have a certain amount of reduction in the expression level of WT1, that they had a worse outcome. To me, that sounds like responding is better than non-responding. Yeah. But on top of that, this effect was also seen in patients who went to transplant. And this is the important point I'd like us to discuss. So you have a patient who has minimal residual disease by whatever assay, and most studies show a worse outcome if they go to transplant with minimal residual disease. But there appears to be a benefit of transplant in the MRD negative patients. Do you think MRD assessment, by whatever means, is ready for prime time in decision making for transplant?
No.
Well, okay, so I
With the caveat that I think we need an assay that we can use everywhere. I think we need an assay that gives us a clear answer, and we have an assay where we say, based on these results, we can change what we do, and it changes outcome. That's what I think we need. Now, do we have data that are informative, that help us make decisions? Clearly.
Yes.
Do we have data on various different assays that have been validated intra-center? Clearly. Do we have something that we can use for everybody where we say our standard approach is X and this leads to better outcomes because it informs a next choice that leads to a change in the natural history? I don't think we're there yet.
I mean, I use the information if I get an MRD positive, and I know, obviously our institute standard is not, commercialized. I think, well, maybe I need to give them another consolidation cycle. Maybe if they've been getting cytarabine-based therapy, I want to give them a hypomethylating agent to get that to be MRD negative. And the transplanters are very interested because even if from their point of view, I'm going to try to get them MRD negative before transplant. If the patient goes into transplant MRD positive, that affects certainly what kind of immunosuppressive therapy they're going to use. It may affect what type of transplant they're going to use because haplotransplants are very much in vogue and we use a lot of them, but they're associated with a higher risk of relapse. So if somebody coming in with MRD disease might be more beneficial to do a myeloablative. So that information right now, though it's not ready for prime time, and I wouldn't advocate that everybody do it, and clearly it's not commercialized or generally available, it is informative on an individual patient basis.
And let me tell you why I would push back a little on that, because I think that's a very valid way of doing it. But here's the caveat. We don't know that if a patient is MRD positive after induction, that pursuing some other therapy to make them MRD negative gives them a better prognosis,
yeah.
right?
And I think that's, I was going to say, I view this from a different perspective. Certainly the patients that go to transplant without detectable residual disease do better. They do better with chemotherapy only. Yeah. My problem is the patients who don't get to that stage. And pursuing more chemotherapy can backfire big time. You could get them very sick, and of course you don't even know that it's going to make them be negative. So they don't do as well with transplant as if they have MRD negative, but that's probably the best I can do for that patient. So I think what we need to do is, what do we do to improve the outcome of those patients after transplant? Do we need to give them, I don't know, we've been doing azacitidine, there are other options.
So maybe you wouldn't give them something before transplant, but it would affect the transplant regimen and your post-transplant. Would you put them on like a TKI or something post-transplant, or what would you?
Yeah, I think maintenance is a really great question when we're dealing with MRD positive patients.
To try to decrease post-transplant.
So I think that's the bottom line here. This is on us, right? We need to develop studies that will look at new ways of a different approach, not chemotherapy, but a different approach, whatever it be, immunomodulation, antibodies, tyrosine kinase, biologic therapies, pre or post-transplant to improve the outcome of these patients.